Okay, I'm the last speaker for the day. I'm from Amy DONAHUE from NIDCD. We're one of the institutes of the NIH, and we support research, and hopefully that will provide some of the evidence that we have talked about that we need today. I'm going to report on a working group on accessible and affordable hearing health care for adults with mild to moderate hearing loss. And Judy Dubno and Lucille Beck served as co-chairs on this working group with me. So in today's presentation, I'm going to talk a good part of the time about the working group background and rationale, especially accessibility, affordability, changes in technology and delivery systems, and highlight some of the professional tensions. I'm going to provide some of the working group research recommendations, tell you about some currently funded projects, and then highlight some challenges and opportunities. Hearing loss as a public health concern, we've talked about this for the last 2 days, so I'm not going to say much about this, other than to say that about 20% of those with hearing loss who could benefit from intervention seek it. Many live with their hearing loss for many years before they do so, and so for many and varied reasons, the needs of the majority of the individuals with hearing loss are not being met. So this research working group happened in 2009, and we looked at the hearing healthcare system as a whole with a public health perspective. And this was a new research area for NIDCD. The overarching goal is to increase the number of individuals receiving quality hearing health care, to better understand the current hearing healthcare system, to identify gaps, including low-cost hearing aids, and to identify innovations and opportunities for the future. The purpose of the working group was to develop a research agenda leading to increased accessibility and affordability. The research recommendations were to be aimed at delivering better hearing health care access and outcomes that are effective, affordable, and deliverable to those who need them, that are implementable and sustainable in clinical and community settings beyond the research environment, and that complement and supplement, not replace, current paradigms. The focus was not on research related to complex technological advancements for hearing aids and cochlear implants, adults with severe to profound loss, or children. These are areas that NIDCD has a very robust research portfolio in. This working group really focused on accessibility and affordability. It also did not include public education. So why mild to moderate? Let me just say that the working group was for adults of all ages with mild to moderate hearing loss. It was not specific to older Americans, but mild to moderate hearing loss represents the hearing status of many older Americans. They are least likely to have had a hearing screening assessment. They are least likely to have used a hearing aid for one of many reasons, yet they are likely to benefit from amplification, and early intervention may lead to better outcomes. Many of these individuals are still active in the workforce, and many will transition to severe hearing loss, needing and requiring more complex interventions and services in later years. Access is as important as affordability. In screening, there are no readily accessible, low-cost ways for the U.S. adults to get their hearing screened. For assessment, we have multiple entry points with competing interest. And of course, with devices, obtaining a device through traditional delivery models is a multi-visit process. Direct-to-consumer, which heretofore has been the primary source of low-cost aids, are available through the internet or magazine, newspapers, which can be consumer beware. And I would say the internet availability doesn't necessarily make devices accessible if you look at income and age use. And so we need better alternatives. Under affordability, we've talked about this many times in different ways over the last 2 days. We know that this includes devices and services. The out-of-pocket cost of one hearing aid is approximately $1,800. 70% require 2 aids. They last approximately 5 years. So you start your replacement cost over again every time you need a new pair of hearing aids. If you look at U.S. household income, 35% of the households have an income of less than $35,000 a year, and the median household income in America is $50,000 a year. So if you look at those two factors and you ask yourself, what is affordable? There are likely different price points for different segments of the population. There are limited scientific data on the specific impact of cost on adoption rates. Most of the data that we do have are from U.S. industry surveys of non-adopters. Cost is cited as a primary reason, and of those most in need, which are those with the greatest degrees of hearing loss, 66% said they were likely to get a hearing aid if there was 100% coverage, and 47% said they were likely to get a hearing aid if the price did not exceed $500. So beyond the purchase of a home or a car, we know that hearing aids and the services can be the third most expensive purchase for many Americans with hearing loss over time. Hearing aid value, which is the benefit relative to cost, is a factor in return and non-use rates. And quality hearing health care is assumed to be the most advanced technology, thereby reducing access to those who can least afford it. There's not coverage, as has been mentioned, by Medicare. There's no coverage or limited coverage by most insurance plans. Instead, we have a reliance on Lions clubs and loaner banks, and this really is not an acceptable public health solution. So we need better alternatives if we really believe that these are necessary healthcare devices. There is a spectrum of socioeconomic capacities in this country, and the NIH mission includes closing the gaps in health disparities. Acquiring hearing health care may be especially challenging for the working poor, and it's important that we remain conscious of the underserved and the economically less advantaged. So let's talk just now for a minute about changes in technology and delivery systems. And these have been talked about. This is the thing about going last. Many people have gone before me, so they've kind of laid the groundwork. So, there we go. So, new and emerging technologies. We know now that auditory assessment, hearing aid fitting is being automated and routinely conducted on PCs. This allows all kinds of possibilities: remote fitting, consumer programming. Hearing aids, the component costs themselves are minimal. Open canal fittings make them far less burdensome. And we've also heard about the smartphone entry into healthcare. There are rapid developments there. NIH has priority areas in mHealth, which is using the smartphone as the mobile platform. They are eclipsing hearing aid functionality. They provide a wireless link, but I also would say that even though ownership rates are rising, age and income variables do influence ownership rates, and so that's something to be sensitive to. Service delivery paradigms. We've seen very rapid changes in that also. The traditional delivery paradigm was you would go to an audiologist or an ENT or a hearing aid specialist, and they would have various devices. The new paradigms include storefront hearing aid sales, internet sales, and telemedicine. And then since the working group occurred in 2009, we've seen the entry of insurers into the delivery paradigm direct to patient. We're seeing a corporatization of hearing health care where the manufacturer is now becoming the provider. And of course, we have mHealth and we have convenient care clinics. And all of these delivery paradigms are going to require changes in the workforce demographics and training. So how did we get to where we are? Eric, Dr. Mann, talked about the FDA regulations that were enacted in 1977. And prior to 1979, audiologists did not sell hearing aids for profit. It was against their code of ethics. So since that time, hearing aids have become an important revenue source for hearing healthcare professionals. We've heard already about some of the professional tensions among our hearing healthcare providers. Where does that come from? You know, it comes from a lot of different things. It comes from disagreement over the gatekeeper status. It comes from differing education and credentialing requirements. It comes from competition for the patient base revenue. It comes from unique belief systems. Each group believes that they provide the best services. And of course, we've heard some of the debate on the FDA regulations. It's been noted already that there is a lack of agreement on legislative strategies for hearing health care. The professional organizations have not uniformly supported reimbursement of hearing aids by Medicare. And I would say that this really is a surprise to many citizens out there. And so if I was going to do my personal editorial comment like Bob did, I would note that a united voice for Medicare coverage of both hearing aids and services would send a very strong message about the value and the importance of hearing to health. As it is, the agreement is limited among the organizations to legislation that supports a hearing aid tax credit, which is $500 per device once every 5 years. This has not passed, but this is currently what's out there. So, with all of that in mind, and that was a very abbreviated version of the background for the working group, what were the charge for the research recommendations? So the charge for the research recommendations were that they were to be aimed at technologies or delivery strategies that are effective, accessible, and affordable to those who want and need them. They are to take advantage of the current and evolving technologies and healthcare delivery models. They are to consider innovative and creative solutions with potential for implementation. They should reflect the current demographics and the varying socioeconomic capacities of this country, and they should be practical and feasible undertakings for the near future. So, you want research. From a list of more than 70 recommendations, and there were a lot of recommendations, the working group members selected their highest priority in terms of importance and feasibility. They were organized into 10 different areas. For the interest of time, I'm going to give you a couple of examples from these, but you can just sort of read that for yourself to get a sense for how we separated them. Okay, so one of the, these are the research recommendations now. One of the overarching research recommendations was that we really better need to document the benefits of hearing healthcare. Beyond hearing speech and noise, we need to understand the benefits of hearing healthcare for general health, economic health, lifestyle, well-being, and family. Under hearing healthcare access, we better need to understand the hearing healthcare system variables, and we also need to understand the patient-centered variables, including the unique needs and concerns across a patient's lifespan. This includes value, socioeconomic status, attitudes, stigma, culture. For screening, we need to evaluate the barriers to hearing screening, to determine the best screening methods, sensitivity, specificity, follow-up rates, and we need to develop accessible screening paradigms using emerging technologies considering the target populations. For assessment, we need to determine the quality and the accuracy of audiometry in different healthcare settings using different means of delivery, using in-person, the internet, the mobile phone. We need to determine the necessary components of assessment batteries to guide the fitting of hearing aids and other interventions as evidenced by impact on outcome, beyond auditory, including cognitive and psychosocial. Under hearing aid technologies, we need to identify the technology variables that influence penetration and utilization rates. We need to identify the minimal technologies that will achieve success, and we need to compare various technologies for various populations, low cost, one size fits all versus high cost. Whoops, I skipped one. For the patient variables, we need to identify the patient variables that predict success. We need to know the factors that influence need and motivation. And we need to better understand the characteristics of those who will benefit from hearing aids or other interventions. We need to develop better outcome measures, a standard set of outcome measures to determine success of hearing health care, and knowing how and when to measure those outcomes is needed. And for aftercare needs, for various service delivery models, we need to better understand the information, patient education necessary, and the effect that will have on benefit and outcomes. Under delivery systems, we need to utilize innovative healthcare delivery systems and models for hearing healthcare. And then we need to modify our current models, both the system and the provider, to increase access and affordability. And workforce and training of hearing healthcare providers. For all of these changes, different models, we need to know the skills, the abilities of professionals and others providing hearing healthcare, whether they're in a traditional or a non-traditional setting. And finally, under medical evaluation regulatory issues, of course, there was a lot of discussion of the FDA. The FDA also served on this panel, I want to say. Do the FDA regulations provide protection for patients, or do they create a barrier for access, thereby delaying necessary intervention? And then there are several areas, specific areas of evidence that are needed, including the ability of consumers to detect treatable hearing loss. So, following the working group, NIDCD widely distributed the working group report. It's on the website. We published our website. We published an open access editorial in Ear and Hearing, which has all of the research recommendations and references. We also published an article in ASH's e-newsletter for a different audience. So from 2009 to present, NIDCD has been encouraging research initiatives for grant applications, and we have been trying to engage a larger research community in these efforts. We have used both traditional and unique NIH funding mechanisms. This is a listing of some of the, we call them funding opportunity announcements that we have had to encourage grant applications to help us go after these questions and receive answers. We've had one for research in hearing healthcare, which basically was very broad and covered almost the entire gamut of research recommendations. We've had support for phased research grants that allow an exploratory developmental pilot phase. We've had funding announcements for grant applications that are dealing specific with determining outcome measures. For small business innovative research grants designed to lead to the commercialization of new technologies. We've also crossed into health services research. We've had a follow-up working group on that. We've have a program announcement out on that. And I would also say that many NIDCD staff have been involved in these activities, both Program Me, who tries to develop, as well as Review, who reviews grant applications. But the truth is, this is a village. All of these calls for grant applications only matter if scientists in the community believe the questions are important and they're willing to take their time and their energy to submit grant applications and go through the peer review process and receive NIH funding. So very quickly, I'm going to give you a listing or just list some titles of a few of the grants that have been funded so that you can get a feel for the types of research that we currently are funding that are, and all of these are directly related to this particular call for grants. The first one is comparing the effectiveness of basic and premium level hearing aids. We don't really have data about full feature versus low feature hearing aids. Minimal technologies for hearing aid success in elderly adults. We have a clinical trial looking at the efficacy of a low-cost hearing aid and a comparison of service delivery models, of best practices versus an over-the-counter simulation. We have an application looking at whether consumers and audiologists can detect ear disease prior to hearing aid use, trying to acquire evidence relevant to the FDA-required medical evaluation. We have a grant looking at disparities in access on the U.S.-Mexico border. We heard about that yesterday. These next two, user-centered control of hearing aid signal processing and improving amplification outcomes in noise by self-directed hearing aid, basically use smartphones and allow the user to make adjustments in noise and fitting to see if they have better outcomes. These next three, these next four are all dealing with screening for hearing loss. Each one is slightly different. One is in a primary care setting. Dr. Walhagen actually is the principal investigator on that. One is using community-based centers. One is using a telephone screening test. And one is using a mobile platform. So each one is going after a different audience and in a different environment. So what are the challenges and opportunities? Well, as I said, you have to have a cadre of researchers who are interested in these questions and believe in the importance of these questions and will submit grant applications. And we have a limited pool of clinician researchers in the audiology otolaryngology world. We also have had heretofore really limited interest in hearing loss research among the other relevant professions: gerontology, primary care, family medicine, outcomes, health services, epi. We've also had limited community participation in research, and this is research conducted in communities outside an academic medical center in partnership with researchers. So this workshop is a real opportunity to encourage engagement of the larger research community in this endeavor. These research recommendations remain timely and important. They require an interaction and collaboration among many different players, and multidisciplinary teams are needed. The reality is it's challenging to program build during tight funding times, but we have been able to do so. Hearing healthcare research is a priority research area at NIDCD. Our Senate report language for 2013 appropriations says, the committee strongly urges NIDCD to support research grants that could lead to less expensive hearing aids so such aids could become accessible and affordable to more people. There's strong support for hearing healthcare research from NIDCD leadership, staff, and advisory council. And you can see slowly but surely our grant portfolio is growing, and we hope to see this continue to grow over the next couple years. So I want to thank the IOM Planning Committee for having this on the agenda. I want to acknowledge Judy and Lou for all of their efforts. And now I'm done. Thank you.